this. Now with Omicron, the problems for the healthcare system are coming down, and it's a little bit possibility to do something else. Nevertheless, I want to give you an overview what COVID-19 means for patients with respiratory conditions. And I want to distinguish this into two parts. So the first part, which is looking to acute disease, which is related to the viral load. As more viral is present, as more severe the illness is, and this is the early phase of the disease. And if we use treatment, and we have treatments today, we use antivirals or monoclonal antibodies. And then the second phase of patients which are more severely ill, which are in hospital or in intensive care, and these are patients in which the virus does not play a role anymore, but the immune response is dominating, and regularly it's hyperinflammation, and the hyperinflammation status causes damage of several organ systems. And if you look what is affected by COVID-19, and this is very special because we have not seen it together with other viruses, it's both the epithelial and the endothelial cell. So alveolitis and interstitial infectious lung disease is the one side of the COVID infection, but endothelitis and the consequences of this inflammatory process of the endothelial cells dominate the other side of COVID-19 disease. And I will come back to this later on. If you look to what happens during alveolitis and in the alveoli, there is one cell population which is of major interest. And this is the monocyte, which develops to be a macrophage. And there are specific macrophages, mainly the M2 macrophages, which are important for organ repair. And if there's pathological repair, and this can take place in COVID, all these secondary complications, which I'm now talking about, occur. So coming back to which comorbidities are risk factors for more severe COVID infection, and this is one of the first papers coming from New York in 2020, demonstrating that this is not respiratory disease. So the risk of patients with asthma or COPD was not increased. However, cardiovascular disease, starting with arterial hypertension, and metabolic disease, diabetes, obesity, and others are main risk factors. And this has been confirmed in our German data. This is the first paper we published in Lancet, demonstrating that hypertension and diabetes, and mainly obesity, are main risk factors for mortality in COVID-19. Why is this the case? Well, now first the data for the chronic respiratory diseases. One of the papers out of the first wave of COVID-19 demonstrating that neither asthma nor COPD is a risk factor for mortality. As you can see here, it's no significance, but looking to obesity, there is an 8.5 increase in mortality in COVID-19 patients. And this has not changed over the different variants which came during the last years. The main reason why metabolic disease and hypertension is so important is the endothelial damage. And this is a paper we published in the New England Journal of Medicine, demonstrating that endothelitis is very present in severe COVID-19 disease. And as a consequence of this inflammatory process of the endothelial cells, there is local thrombosis. And this thrombus formation is more in patients in which the endothelial had been stressed by further disease, by comorbidity. And this is a case in hypertension, it's a case in diabetes where endothelial cell damage is a typical finding. And this is a very good explanation why this is a risk factor. And I show you here one of our patients from the intensive care unit, and what you can see here is RDS, and the reason for this is a breakdown of the endothelial barrier. So lung water, the extravascular lung water increases by far, and this is a clear consequence of the endothelial part of the disease. Now I come to where are we now? And you all know we are in the Omicron era, and Omicron has changed a lot because it's much more transmissible than every other variant, but it's not so virulent. Omicron does not have a pathogenicity factor, a replication factor in the alveolar cells and in the lung tissue. No question about, there are still patients who are severely ill with Omicron, mainly the immunosuppressed patients, patients who are not vaccinated. We just got data 3 days ago from Hong Kong, and in Hong Kong the mortality with Omicron disease is up to 5% in a population which has never been vaccinated and which do not have immunity due to infection, due to the zero COVID policy for more than 2 years. So if you are not prepared, even Omicron can cause a severe disease, and this underlines the importance of a good vaccination program. But coming back to Europe and also to the Gulf region, here patients which are really immunosuppressed are the patients at risk. And these are the transplant patients. And as I showed here, lung transplantation goes worse than kidney, goes worse than heart, goes worse than liver, and goes worse than bone marrow. And one of the reasons for this is the need for higher dosage of the immunosuppressant agents in lung and kidney disease, and mainly mycophenolate or azathioprine are drugs which reduce the immunity against SARS-CoV-2. The second group, which is really at risk, are patients with autoimmune disease, and mainly when they are treated with B-cell depletion therapy. If there's no B-cell present, there's no antibody against SARS-CoV-2 present, and the main substance we use in Europe is rituximab, a CD20 antibody. And the last high-risk group are the hematological cancers, patients with leukemia, with lymphoma, and this is more if they are in an immunodeficient status, which means if the immunoglobulins are down. And in these patients group, the mortality is still really high, and I will show it later on. So first, I want to start with different types of chronic lung disease. And one which is a hot topic in respiratory medicine now is interstitial lung disease, and mainly IPF, idiopathic pulmonary fibrosis. And there are some data sets analyzed about the risk for fibrosis patients when getting COVID-19. And what you can see here is there is an increase in mortality in patients with interstitial lung disease. However, it's only in some subgroups. These are the patients who have been more severely ill, lower vital capacity, lower diffusion capacity, more advanced disease before COVID comes, and again, patients with comorbidities. And this is a typical problem because corticosteroids are a main treatment option for interstitial lung disease. patients with interstitial lung disease are obese as a complication of the corticosteroid treatment. And as you can see, if you are obese, your rate of severe complications and mortality is going up. And I show you one of my patients with interstitial lung disease, that you can see here this reticular pattern with, we call it tracheobronchiectasis. And then she got a COVID infection, and this picture increased dramatically, and she died in between days. So what to do after COVID disease in patients with lung fibrosis? Lung function measurement is important, and if you look what is the best parameter in lung function measurement, in lung function analysis, and this is shown here in this paper, is diffusion capacity. If diffusion capacity is down, and if diffusion capacity does not improve 3 months after COVID infection, you need to increase your medication to counterpart these disease progress. Well, if I look at other diseases, it's different. And this is a very nice paper from California looking to asthma patients. And as you can see, neither asthma nor COPD, as I said before, are diseases which increases the risk for mortality together with COVID-19, with one exception. And this is what is written here. If there is no adequate treatment of asthma, the risk for mortality, the risk for hospitalization increases. And this is a very important message for every GP, for everyone treating asthma patients. You need to optimize the asthma treatment, which means ICS has standard treatment, 1 or 2 of the bronchodilators as additional treatment. As you have discussed during the last session, biologicals are more and more in place in asthma. And in the beginning of the COVID pandemic, it has been questionable whether biologicals, because they reduce inflammatory cytokines and can reduce theoretically the response to the virus, the innate immune response to the virus, which so it was questions whether biologicals should be stopped. However, this had been the first registry study in 473 patients, and as you can see, all the biologicals which are approved in Europe, Benra, mepolizumab, the anti-IL-5, stupilumab, the anti-IL-4, anti-IL-13, and omalizumab, the anti-IgE, had been included into this analysis, and altogether there was absolutely no signal that biologicals increase the risk for more severe COVID-19 disease. And the same had been confirmed by the Belgian severe asthma registry. Also a huge number of patients, half with omalizumab, half with other anti-IL-5 biologicals. And again, there was no signal for an increased risk by using the biologicals in COVID patients. In contrast, there was a signal that if you stop the biologicals during a COVID episode, besides COVID, you see an exacerbation of asthma, which is worse for the prognosis. Other chronic lung diseases, cystic fibrosis, patients who are chronically infected, mainly with Pseudomonas, so patients in which we were very concerned that there is an increased risk in COVID-19 disease. However, again, a big registry analysis does not confirm any risk, even in cystic fibrosis patients, COVID-19 is no more severe than in the total population. However, there is one disease in which it is different, and this is tuberculosis. If tuberculosis patients suffer from COVID-19 in addition, the risk for a more severe course of COVID, but also for an exacerbation of the tuberculosis itself, increases. And the most important issue in TB patients who suffer from COVID-19 is to hold the anti-tuberculosis treatment, the tuberculostatic treatment. If you stop the anti-tuberculostatic treatment, there will be a dramatic increase in the severity of the tuberculosis and an increase in mortality. I talked about patients with autoimmune disease, and this is a characteristic of the American Autoimmune Disease Registry about the risk factors for more severe COVID diseases in those patients. And what is very, very clear is one of the most important risk factors is corticosteroid treatment. If you use more than 10 milligrams, more than 15 milligrams of corticosteroids orally a day, the risk for more severe COVID disease increases by far. This seems to be a little bit contradictory because we use dexamethasone as a treatment option in more severe COVID-19 disease. However, patients on long-term corticosteroids reduce the capability of the innate immune response, and this is mainly the fact if you focus on interferon and TNF-alpha response, and this makes the innate immune system no more strong enough to overcome COVID-19. And here, a Danish population-based cohort study, again, in patients with immune-mediated inflammatory disease. And as you can see, systemic steroids again came out with a higher risk of mortality in COVID-19, and staying with the biological therapy with those who overcome the rheumatoid disease was more beneficial than harmful. So you should have a look on corticosteroids, you should reduce them. Some of the immunosuppressants have an impact of COVID. I mentioned mycophenolate and azathioprine, but some do not have harmful impacts. Tumor patients, is there more risk for cancer patients to die from COVID-19? And altogether, outside of the hematological disorders, leukemia and lymphoma, the risk is not very much increased. The patient group with the highest mortality is the bronchial cancer patient group, and the reason may be that this is a patient group in which the lung is damaged. There is lung disease, very severe lung disease for a very long time, and though the possibility to overcome the impairment which came by COVID is lower than with others. And again, you can see a systematic review of patients with lung cancer and COVID-19 disease, demonstrating that in these patients there is a small increase in mortality. And the determinants of COVID-19 disease severity in cancer patients, again, it's the same as what I have said before. It's patients on corticosteroids, it's patients with more advanced disease, so more metastasis in bronchial cancer, and as typically for all diseases, kidney failure, acute or chronic kidney failure is the risk factor for an increase in mortality. With this, I want to come to my last slide. And this is what I started with, the high risk of patients who are transplanted for COVID-19 and the high mortality rate. And as you can see here, a very nice paper in which lung transplant patients with COVID-19 were compared to lung transplant patients suffering from another virus, RSV, respiratory syncytial virus. And as you can see here, the COVID mortality is 12%, the RSV mortality is 3%. So COVID causes in transplant patients a much more severe disease than other ones. There are a number of studies now demonstrating that the vaccine response in transplant patients is very low, even with a third shot or fourth shot. And for lung transplantation, I can say about 60% of the patients do not have a vaccine response, do not produce antibodies, and are not protected. And if these patients suffer from COVID-19, the mortality is really high. And there's now a possibility what to do. This is a new antibody available in Europe and in the US now, Evusheld, an antibody which produces neutralizing antibodies for 6 to 9 months. And we use this Evusheld for pre-exposure prophylaxis to reduce the risk for severe COVID-19 disease in those who failed vaccination. And this is a study which confirmed this, just published in the New England Journal of Medicine. So to conclude, patients with chronic respiratory conditions show only in some circumstances an increased risk for severe COVID-19. The patients with advanced interstitial lung disease, the cancer patients, the patients after lung transplantation. For other ones, asthma, COPD, other chronic diseases, there's no increase in risk if patients had been treated adequately. And this is a task for every respiratory physician to optimize the treatment in asthma and COPD for other respiratory diseases. Biologicals are not harmful in COVID-19, so stay with the biologicals even there's COVID disease, and then optimize the vaccination state. Yes, corona vaccinations, SARS-CoV-2 vaccination is important, but there are other viruses, mainly influenza, pneumococcal disease, and others which play a role in chronic respiratory disease and should be used. And last not least, for the more severely ill patients, the advanced patients with chronic respiratory disease, keep with face masks, keep with distancing, because this reduces the risk for being infected. And with this, I want to stop. So it's not enough to be good. Sometimes we have to be better. And this is in terms of respiratory patients with respiratory conditions, we also need to look whether our treatment is guideline adapted and is the best one available. Thank you very much for your attention, and I would be very happy to get questions.
Hi. Yes. So, Tobias, that is very nice of a German person to quote Winston Churchill. We have a question from Ashraf Zahabi.
Hello. Professor Welte, it's a pleasure to have you with us today. I have a couple of questions. The first question is with regard to your data that COPD patients are not at higher risk of severe COVID. There are other data on the opposite direction. There is a big data from the UK having more than 8 million people with 14,000 hospitalization and 5,000 people who died from COVID, where the odds ratio of severe COVID and mortality was as high as somebody who's having interstitial lung disease a little lower than cancer. So how do you explain the contradictory findings?
Well, this is a problem of adjustment, and COPD patients very often are older, and what is the main important issue is they have more comorbidities, and the main comorbidities is cardiovascular disease, is diabetes, and very often is obesity. And if you adjust this for these well-known comorbidities, the risk of COPD alone is going down. This is something we always have to take into account. Patients with chronic respiratory diseases, and COPD is one of the main examples, are patients with a high number of comorbidities. And we should not only focus on COPD, we must treat the comorbidities adequately. And this mainly is with regard to cardiovascular disease.
Sure. Thank you very much. I could understand why a country that did not have mass vaccination, you mentioned Hong Kong, I didn't know that they were not taking the vaccination nationally. I could understand why the mortality would be high from Omicron, but recent news have implicated that even Germany suffered from Omicron with higher number of mortality, even higher than when Delta was around. Is that true?
No, it's not true. So the mortality in Germany for Omicron is 0.1%, and you have to have in mind mortality for flu, for example, is 0.5%. But for risk groups, and I pointed out the main risk groups, which is hematological disorder, transplantation, and autoimmune disease, for these groups, really mortality is high. And in the lung transplantation group, and Hanover, where I'm from, is the biggest lung transplant center in Europe, in the lung transplantation group, if you suffer from COVID-19, mortality is up to 20%. So these are special circumstances. But for the normal population, mortality is low. However, this is true in a country with a high vaccination rate. And during 2 years of COVID pandemia, with a high rate of people being infected. So in Germany, altogether, 95% of the patients show antibodies caused by vaccination or infection.
Thank you. So we have another question.
Okay, well, again, Professor, thank you for the excellent presentation. Early reports, at least here from UAE, looking at the prevalence of, or incidence, I should say, of COVID-19, we saw that it was less among smokers. Any association between smoking and less chance of getting the infection?
Yeah, that's a very good question. And there had been a lot of debate about the first data coming up for people who smoke, showing a lower risk for COVID-19 complications. But altogether, looking now to the database of 2 years of pandemia, there's no signal for smoking. There's no signal for benefit, but also no signal for harm. Nevertheless, smoking is one of the main risk factors for chronic diseases, not only pulmonary, but also cardiovascular and other ones, and smoking cessation should be one of the major aims for every respiratory physician. But for COVID-19 disease, the role is not very important.